1 second. See, this goes live on Dr. Raslin, live on YouTube,
Perfect.
which puts it on the internet.
Yeah, that's fantastic.
Yeah. Yeah, I couldn't believe it when I found it. I said, man, from your computer, you have like a TV studio.
Yeah.
And we have a lot of content. I'm having trouble here with my computer. Oh, here's a little jammed up here. It's a little slow. Oh, man. I'm sorry, I'm having trouble getting the YouTube connection going. Hold on. Hold on. I'm having a hard time getting a hold of this. Never happens. Only happens when there's not much time. Yeah, just give me a second, Doc. I usually don't have a problem getting hold of YouTube.
No problem.
Okay.
I got a notification that this is already live stream, and I see a YouTube link on me on I can see the YouTube, and it says live on YouTube right now. So it seems like we are already live.
Yeah. Okay. Getting there. Okay. Looks like we're going. Okay. Geez, everything's slow. It's very unusual. Okay. Okay. Okay, we got it going. Okay. Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from Neurosurgical TV. That's where we're based out of Miami Beach. We have the pleasure of having Yemen Neurosurgery Grand Rounds headed by Abdel Rahman Aliter. He obtained the services of Ahmed Raslan, a neurosurgeon from Portland, Oregon. That he's gonna talk about updates on epilepsy. And I'd like to introduce Abdel first to introduce Dr. Raslan. Hello, Abdel, it's all yours.
Okay. Wiltertanti Society and Neurosurgical TV are introducing one of the best neurosurgeons in the USA, Prof. Ahmed Rislan, professor and interim chair of Oregon Health and president of North American Neuromodulation Society. He has a American Board of Neurological Surgery. We'll talk about updates in epilepsy surgery.
Thank you.
Okay.
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 All right, I will start sharing.
Yes, thank you.
Yes.
All right, well, can you guys hear me very well?
Perfect.
Well, thanks. Let me
Yeah,
first
perfect.
thank you, everyone. Let me thank first Dr. John Bennett for hosting this, the Neurosurgical TV. I've heard about them and I've seen some of their work before. I also like to thank Abdurrahman Al-Itr from Yemen and Dandi Society, and Ahmad Al-Ghanimi from Dandi Society of Yemen also, and the World Federation. So thank you very much. So I am a neurosurgeon. I'm originally from Egypt, but I am practicing in the United States now for 21 years. And I'm the professor and chairman of neurological surgery at Oregon Health and Science University. I'm going to take you into a journey about epilepsy surgery, where we have been and where we are right now, and where the future is heading. Because epilepsy surgery is one subset of neurosurgery that has undergone a significant change and significant update over the past 15, 20 years. There is a lot of changes in what epilepsy surgery used to be and what it is right now. So without further ado, I'm going to go straight ahead. These are my disclosures, and some of them are relevant to the talk. Some of these companies produce devices that are used for epilepsy and will be used in epilepsy treatment. This is the campus of the university where I work from the air. Okay. So what are the candidates for epilepsy surgery? And we are going to talk here about the classic or conventional paradigm. This is what has been going on for treatment of epilepsy since the 50s, all the way until perhaps 10 or 15 years ago. And the most commonly treated epilepsy syndrome is the temporal lobe epilepsy, or called hippocampal sclerosis. And this could be idiopathic or could be induced by something else. And then extratemporal epilepsy or catastrophic epilepsy, and then secondary generalized epilepsy. And the resective surgery focused on this particular part, which is temporal lobe epilepsy. We performed resective surgery. That was the type of surgery that is considered curative. And there is a level 1 evidence that epilepsy surgery is far superior than medical treatment for treatment of temporal lobe epilepsy. This is the work of Samuel Weber, published in the New England Journal of Medicine in 2001. Radiosurgery has been tried, but now it's fell out of favor. There was a trial called the ROSE trial, which is started in University of California at San Francisco, but did not meet endpoint. Disconnection surgery is the corpus callosotomy, is used primarily in kids who have drop epilepsy or catastrophic epilepsy, not to treat epilepsy, but to treat the generalization of epilepsy to prevent catastrophic drop. Vagus nerve stimulation and deep brain stimulation are also options that are used for multifocal epilepsy and idiopathic generalized epilepsy. And then the diagnostic surgery, which is, by the way, the diagnostic surgery is the area where it's undergone the most updates and most change and evolution. So if you go to the classic paradigm, how did we treat epilepsy syndrome? This is what we did. If you had in a focal epilepsy, one area of the brain that causes epilepsy, and everything lines up, concordant data, meaning that the imaging, the neuropsychological testing, and ictal EEG, 4 things, all are concordant, then you provide resection. assuming that the part of the brain is not eloquent. If you have focal epilepsy, but without concordant data, meaning you have bilateral temporal lobe epilepsy, or you have the ictal EEG from one side, but the semiology from the other side, you place intracranial electrodes to decide which side is that. If you have focal epilepsy with the zone determined from diagnostic surgery, then you can do resection if the lesion identified or not co-localized those functions, meaning you didn't have concordant data, you placed electrodes in the brain, and then you now are able to identify where the seizures are starting from. You could remove that area if it is not carrying any function, if it's not co-localized those functions. But if it is an eloquent area, such as language cortex or motor cortex, then you couldn't remove that part. And that would not be a condition where you can treat with surgery. If you had multifocal epilepsy, then you would do vagus nerve stimulation. And if you had catastrophic epilepsy, then you would do disconnection surgery. This is what the world lived in, perhaps from the 50s and 40s, from the work of, Penfield all the way till, perhaps the 2008, 2009, late 2010. We know we cannot remove both temporal lobes. This is the work of Scoville and Brenda Milner. This is in Boston, where they tried to do resection of both temporal lobes, and that led to the famous case of patient HM who could not hold his memory for more than 5 minutes. This was a subject for multiple books and movies and stuff, and HM, I think, died in 2008. But now we know you cannot remove bilateral temporal lobe. So if you have bitemporal epilepsy, resection is no longer an option. And this led to groups of conditions weren't amenable to resective surgery and perhaps not amenable to any type of surgery. And this is generalized epilepsy, bitemporal epilepsy, most cases of bifocal epilepsy, focal epilepsy with cortical foci, co-localized with function, focal epilepsy not identified on grid placement, and deep-seated lesion. What did we do for this? Either we didn't do surgery, or we tried to do vagus nerve stimulation, or we did a surgery that was more risky than beneficial, something that's called subpale transaction. So these were conditions that weren't amenable for cure and pretty much ignored. What happened over the past 10, 15 years? Well, a multitude of things happened simultaneously, not through the same single technology, but multiple technology all happened together that led to change in epilepsy surgery. The first and most important of which is this idea of mapping the brain and doing intracranial diagnostic surgery, but not with surface grids or surface electrodes, but with electrodes that penetrate the brain, what's called stereo EEG. And then robotics came along because stereo EEG electrodes require placement of at least 16 to 20 electrodes, and using conventional frame-based stereotaxis not only will lead to error, but also will be very time-consuming and risky. So robotics came along to aid in the placement of stereo EEG. In addition to that, laser ablation to burn the brain tissue in situ without having to expose and do a craniotomy was available. So that facilitated the treatment and made the results obtained by stereo EEG manageable or actionable. And then responsive neurostimulation and deep brain stimulation and mapping advances. I'm going to actually go through each one of those, give 5 minutes on each one of those to explain what is this and why is that important, how has that changed epilepsy surgery. So let's talk a little bit the first one. This is a classic intracranial system that is called a grid. You had to make a big cranie, and you have to determine the size of the craniotomy. So in other words, your pre-test hypothesis, your understanding about where seizures are coming from had to be pretty accurate in order to determine where to place the cranie, and then place that surface grid. And then you could supplement that with a couple of more strips. You can see here the strips on the side because you cover the problem. The problem with this approach is good, but this has several problems. First problem is that the patient needs 2 surgeries regardless. So whether this was a positive exploration or a negative exploration, you have to open the patient back to remove this. Second, you have to determine from the head where area you're going to open. And no matter how big your cranie is, you have left a lot of brain uncovered. Second, it ignores the sulcal surface. It's only the gyral surface, and 2/3 of the sulcal surface is 2/3 of the cortical surface is in the sulci, so you're ignoring that. And all deep-seated structures are not amenable to this. The hippocampus is not amenable to it. All the medial structures, singular gyrus, whether it's anterior or posterior. So this approach was good, but was very limited. And these are the electrodes. They come in various shapes and forms, and you had to implant them by surgery and keep the patients in the ICU. You couldn't keep them for more than 5 or 7 days because those wires will come through the skin and they will cause CSF leak. This is what it used to do. We implant them and draw a map, and the map would be for seizures and functions, and based on that, determine what to do. And you had to keep them in the EMU for probably, as I did, maybe up to 5 days, perhaps 7 maximal, and you couldn't leave them more than that. The problem was these that their postoperative course was a little rough. They can cause add air to the brain, blood, and the complication rate from those electrodes was pretty high. And this is one study that was published in 2016 and showed that the subdural electrodes hemorrhage risk was anywhere between 3 to 16%. Infection was 2 to 12%. CSF leak 12%. These are pretty high rates. I mean, the number needed to treat to produce one complication was 7 or 8. In any epilepsy center, if you do 100 epilepsy surgery, that means you're going to have 15 or 16 patients every year with complication. And sometimes that's not the same patient that had the same complication. So the total number of patients that would have complications of this was pretty high. Here comes along stereo EEG, which is a completely different concept. And stereo EEG here doesn't mean stereotactic, it means three-dimensional. And this is looking at the brain as this three-dimensional structure. And instead of looking at a 2D map on the surface, you're looking at the network of epilepsy. And this stereo EEG was actually available in France since the 60s. This is how the French neurosurgeon approached epilepsy. And the Talairac Atlas and the Talairac frame were all developed to place those electrodes, and you used angiogram to avoid injury to blood vessels on the sulcal surface. And these are the shapes of the electrodes. They're implanted via a small hole with this metal bolt here that anchors to the skull and carry the electrode. The electrodes are thin, and these are the systems that we use to implant them. You could keep them in the patient hip up to 30 days. They're very well tolerated, and you could implant them bilateral. There is no part of the brain in which you couldn't target with stereo EEG. They're less superior than grid on the surface because it doesn't give you 2D maps, but they're more superior in targeting many, many parts of the brain. And you can keep them in the EUM as long as you want because there's no CSF leak, and they're not associated with hemorrhage or infection or CSF leak. And therefore, you could study the patients much, much longer, and patients tolerate this much better. Okay? That's the difference between subdural electrodes on the left-hand side, and this is an example on a grid and depth, versus stereo EEG, and this is done using a frame-based placement. If you compare stereo EEG with subdural electrodes, you can see a big difference in the hemorrhage risk, up to 16% and less than 1%. Infection is 2.3 to 12, 1 to 3.8%. And actually, I can tell you that my own series, I have implanted at least 250 patients with stereo EEG. I had 1 infection, so that means 0.4%. It's a pretty low rate of infection. CSF leak is very, very low. Intraparenchymal placement, this is what you do with stereo EEG, but that could happen with subdural electrodes. Cerebral edema is very unlikely to happen with stereo EEG. So the complication rate is categorically and profoundly different with stereo EEG. And this allows us to study conditions such as bitemporal epilepsy, study deep-seated epilepsy, hypothalamic hamartomas, periventricular. So now we can diagnose epilepsy much better. We can understand where the focal onset starts, how far and how fast it spreads into the brain. That gives you a better diagnosis. So this is the first update. This approach, because it's so powerful, it has been used outside of epilepsy. This is the front journal of a very important journal called Biological Psychiatry, in which the group at Baylor College of Medicine is using the same stereo EEG approach to treat depression. Now, they want to understand what's the biomarker of depression and how the network of depression gets activated, and they use stereo EEG. So stereo EEG actually now is expanding beyond and outside the field of epilepsy. And in fact, there is at least 5 trials currently in the United States to use stereo EEG in conditions such as depression, OCD, chronic pain, and other conditions as well. So the first one. Second update is the robotics. And the robotics in epilepsy surgery is very, very important. Now, there are many, many examples of robots in medicine. This is a robot, and there's very different types of robots. And the robot we use in stereo EEG is very similar to that robot. This is the robot that does repetitive, mundane job. This is actually Tesla factory, and this is a robot that manufactures the Tesla car. This is a humanoid robot. We don't use that in neurosurgery. It may be used in the future in the operating room to bring equipment and stuff. This is a telecontrol robot. This is the rover, Mars rover. That's a different type of robot. We don't use that, but that's the closest robot we have to the Da Vinci robot, which is not used in neurosurgery, but used in general surgery. And this is the animal-shaped robot. These are made by Boston Dynamics. These are robotic dogs. They're used in war zones, and then it can be sent somewhere where humans cannot be sent. We gonna use robots in many things, and automation of different parts of surgery is our fate. But this is an important book here about what's the rules of human in the area of automation, and it's basically the premise of this book that both healthcare and education will be the latest areas of industry in which robots will invade or automation will prevail. There's many industries where computers and robots will prevail and will replace humans. But in healthcare and education, these are areas that we're still going to need humans. But surgery in general is changing. What we consider is surgery is going to change. And our conventional definition of surgery is that you have to make a cut and have bleeding has been changing since Lars Lexell. Lars Lexell devised a type of surgery called radiosurgery in which there is no incision. And I'm going to explain what I mean by that. Okay, so look at this. This is a flow chart of a common surgery. This is the microvascular decompression for trigeminal neuralgia. Everything you do in this surgery is in this chart. You position the patients, you do open soft tissue exploration, you do a craniotomy, make sure the transverse sigmoid junction is exposed, you open the dura, you do vascular decompression, and you close. So everything you do in microvascular decompression in this chart. This is the same chart for deep brain stimulation, positioning, prepping, fiducial placement, registration of CT scan. But the most important step of deep brain stimulation isn't on that chart. Does anybody know what step that is? It's planning. It's planning the trajectory. This is a cognitive task. It is not no longer a manual task. And that's the most important part of that surgery, is to determine what is the path for the electrode, what is the entry point, what is the target. And that's completely cognitive. It is not manual whatsoever. So the cognitive domain of surgery is increasing as we advance. And the holy grail of surgery is to reduce the burden on the patient while increase the sophistication of intervention. And we now do that using robotics. You use the stereo EEG. So with stereo EEG, you're able to target deeper parts of the brain, have a more elaborate surgery, but with less invasiveness. And in order to do this, you have to have this cognitive part. So surgery is going to include greater cognitive domain, and even conventional surgery that you do in the future, you're probably going to do complete virtual rehearsal of any surgery before you approach the surgery. So I want you to understand that surgery worldwide is going to change, and radiosurgery is a great example in which there is no manual part, it's all cognitive. There's another surgery now also called high-focused ultrasound. High-frequency focused ultrasound is a very similar surgery. There's absolutely no incision. You do the surgery by pushing a button that says sonicate. The ideal surgery of automation is a surgery that has a substantial pre-procedure cognitive domain, multiple repetitive steps. There's need for precision and need for efficiency. And guess what? Stereo EEG is an example of that. That's an example of the robots. This is a company called Zimmer Biomet that owns this robot. That's the robot we use, and that's an example of the electrodes, the targets here, amygdala, anterior hippocampus, planum temporale, posterior hippocampus, orbitofrontal cortex, insula, anterior cingulate, long insular electrode, posterior cingulate, and left. And this is video of one of the surgeries using robot. But the most important part of this video is that I am not scrubbed. I am in the background because the most important part of surgery isn't placing the electrode, is actually writing those numbers and the cognitive part of surgery. A resident is going to inject local drilling.
Sorry, John.
And you place the electrodes. This is how you place the electrode. With the bolt. Okay. All right, so Now I showed you why robots are important and that the new way of doing surgery, which relies on cognitive component, computers and artificial intelligence will help with the cognitive component, but there needs to be a human driving the entire process. Okay, so we talked about stereology, we talked about robots. Now, how about laser? So, does you know who that is? Austin Powers. All right, so laser is a technology in which you could, destroy the tissue inside without opening, and it has been used for temporal lobe epilepsy, and it is, it happens that the hippocampus is an ideal target for laser ablation because laser ablation requires this phenomena called heat sink, which is achieved by spinal fluid flow, and the hippocampus is surrounded by CSF in all three directions, except the 10th. So when you send the heat into the hippocampus, it stays in the hippocampus. It does not spread into the brain. That's an example of a laser ablation of the hippocampus. This is the machine, and you can use it for hippocampectomy, and you can use it for other things as well. And the results are similar, slightly inferior to open resection, but it was a significant lower side effect. So on the left-hand side of the left of the brain, if you want to avoid cognitive side effects, laser might be a choice, especially for those who are averse to side effects or want to preserve their cognitive function. This is also another use for laser, which is deep-seated lesions that otherwise you couldn't target with open surgery. This is an example of hypothalamic hamartomas. This is a very deep-seated lesions, only 6 or 7 millimeters. It causes a classic syndrome called gelastic seizures, which you couldn't treat with open surgery. If you try to reach this part of the brain with open surgery, you're going to cause a lot of side effects. You can try to use an endoscope, but look here, the ventricles are very small. So it's very hard to target this. Laser is actually very, very effective in treating these conditions, as well as periventricular heterotopia. So now we have a tool to treat conditions that we diagnose with stereo EEG. So you place a stereo EEG, you diagnose the patients with occipital onset zone from a deep-seated lesion. Now you can treat it because in the past you couldn't treat it. And because you couldn't treat it, you didn't care to diagnose it. Next is this idea of closed loop system. And the closed loop system is a system that updates its output based on an input from the patient. The idea here is that since seizures and epilepsies are intermittent episodic phenomena, can we read out the brain activity and only deliver treatment when you are about to have epilepsy? A very similar concept to the pacemaker of the heart. The pacemaker of the heart is an implanted device that reads out your electric activity of the heart, and when you have an arrhythmia, it triggers a shock to bring the normal heart rhythm back. Can you do the same thing in epilepsy? And the answer is yes. That's the mathematical principle behind closed loop system. But for the brain, there is multiple closed, and the nervous system, there is multiple closed loop system now. There is a closed loop vagus nerve stimulation, there's closed loop spinal cord stimulation, there's closed loop deep brain stimulation, and there's closed loop responsive neurostimulation, which is used for epilepsy. But what is the potential benefit for that? You get a better physiologically guided output. The device is not on all the time. You can tackle different aspects of the disease. It improves battery life because the stimulation is not on all the time. It may mitigate suboptimal placement. An ideal closed loop system is a system that's on demand, closed loop, adaptive, responsive, and energy efficient. This is the device that we use for as a closed loop system. It's called NeuroPace, similar to the pacing of the heart, but now pacing of the brain. It detects an automated detection of epileptiform activity, has a double durable sensor, detection of stimulation through the same electrodes. You can have a depth electrode or a surface electrode. It delivers brief stimulation in a very short 200 milliseconds, 0.2 second. 4 channels, there's 2 electrodes. The sampling rate, the readout from the brain, it reads brain activity 250 times every second. And it can store 360 seconds, 9 minutes of brain activity. And the patients can download that activity. So not only this system is a treatment and closed system, but it's also an ambulatory recording of your brain activity, which you can look at over weeks and days and months to determine what is the pattern. Do you get the seizures in a particular time of the month? Do you get the seizures after a particular type of medication has been used? So there's a lot of benefits for that system. And this is the results of the pivotal trial that shows that the sham arm, which is the gray arm, is at much lower seizure reduction rate compared to the blue, which is a treatment group. So the treatment group has a significant reduction of epilepsy. This is a picture actually from the first responsive neurostimulation I implanted. This was now, oh, can't believe it, 10 years ago. And similarly, talked about RNS, you can talk about deep brain stimulation. If you notice this graph here, is very similar to this graph. Deep brain stimulation, this is the study from the anterior nucleus of the thalamus, the Sante trial to treat intractable epilepsy. And deep brain stimulation is also used, and we use deep brain stimulation when we cannot determine the ictal onset zone. So something to know about the responsive RNS, the closed loop system. In order to have a good closed loop system, you need to implant a device in a region of the brain in which you can read out the epilepsy activity. That's usually the ictal onset zone. Sometimes you cannot determine where the ictal onset zone is. In this case, deep brain stimulation is superior because you don't have to implant it where the seizure onset occurs. You implant it in the same part of the brain every time, which is the anterior nucleus of the thalamus. Why the anterior nucleus of the thalamus? Because it has very strong connection through the Papes circuit to the hippocampus. So it's very effective in frontotemporal epilepsy. The problem with anterior nucleus of the thalamus stimulation was the high rate of depression on the pivotal trial, which is now mitigated by different type of placement in which we implant in the mammillothalamic tract. So the depression rate is much, much lower. And this is now an approved treatment. The FDA approved deep brain stimulation for epilepsy in May 2018. We now use different targets other than anterior nucleus. We use the anterior nucleus, but we also use centromedian nucleus on pulvinar. And there's multiple studies in that area. So I took you through the journey of the things that has changed. I talked you through stereo EEG versus electrodes. I talked to you about robotics. I talked to you about laser. I talked to you about, closed loop systems. I'm going through a lot of things quickly because we have to cover lots of ground. But one other thing that led to improvement in epilepsy surgery and change in epilepsy surgery is improved mapping. How can you map the brain and understand which part does what, which is we call functional cortical localization. So there is newer understanding based on this new mapping. So this is a now about 6 or 7 years old paper that published by the UCSF group to show that the classic model for language connections, this is the white matter, is not just the arcuate fasciculus. There is at least 8 tracts that are responsible for different components of language production. In the blue one here, which is called inferior fronto-occipital fasciculus, IFOF, which is the discovery of function is largely attributed to the work of Hugh Defoe in France and Montpellier, showed that, it's not just the arcuate fasciculus, it's the IFOF and the superior longitudinal fasciculus. And in order to preserve all components of language, you need to perform your surgery with the knowledge about all these tracts, not connecting the Broca to Wernicke. There's also this new concept of passive mapping paradigm. Classically, we map the brain using electrical stimulation. We send an electrical impulse into the brain, and the electrical impulse will stop the brain activity. There is another way of doing this with passive mapping. We read out the brain activity, and this readout allows us to test the entire surface of the brain with one task. It avoids and minimizes stimulation, and stimulation can induce epilepsy. Can be done intraoperatively or extraoperatively, and it's well validated for speech and motor mapping. And this is the work of Nathan Crone in Johns Hopkins that showed that, you can detect the change in the power of special frequency band, in this particular case, the gamma band, that correlates to the function. For example, when you try to move your hand, the gamma activity in the precentral cortex will increase. When you are listening to music, the gamma activity in the superior temporal gyrus will increase. You can use that knowledge to determine whether a part of the brain is active during a task, which would tell you that this part of the brain is involved in that function. This is another method of mapping the brain without delivery of stimulation. It's very powerful. You can apply the task one time and test the entire surface of the brain that's covered by sensors. You can also test some unusual functions. You can apply listening, solving Rubik cubes, sticking out the tongue, kissing, any type of function could be tested here. And we can also test connectivity using what's called, cortical evoked potential. This is another method of mapping, where it's delivery of a single pulse of stimulation, not continuous stimulation, but a single pulse of stimulation. All these things together have led to improved understanding and mapping of the brain, which allow us to be precise and allow us to perform the surgery with much higher safety and much higher effectiveness. This is passive mapping from one of the cases I've been doing. Sorry, this is recorded via cell phone.
but this patient is going to be asked to stick out their tongue and watch what will happen. This is the grid over the, see that? That's sticking out your tongue. And these are the regions of the brain that are involved in tongue movement. That's an example of passive mapping. Now, do I take that information and apply it directly for surgery, so avoid these areas? The answer is no. I chose these areas and I deliver stimulation. So I use passive mapping for opting in, and I use stimulation mapping for opting out. So I determine the region that's of interest, and I use that to narrow the scope of stimulation mapping. So another one. This is also another
go
method
ahead
of
and
mapping
relax.
using a much higher density of sensors. This is somebody who's
do thumb and
undergoing an
middle
awake
finger.
brain surgery, and we have these
Thumb and
deformation
middle finger
sensors in their
together.
hands.
Doing it.
Yep, you're
Just
doing it.
okay.
You're doing a great job.
And this is the sensor. You have about 1,000 of these sensors. They're very tiny. So instead of recording from only 64 channels, you can record from very much higher number. And this is what you get. So this is an example of a high resolution grid, much higher resolution, 1,000 points of recording over the area of the motor control area. So here is central sulcus and functional boundary here, which is, so between the red line and the black line is motor area. Behind the black line is sensory area. And in front of the red line is the supplemental motor area. Now, this patient is going to do a grasp movement. Let's watch what's going to happen. Watch, and then this blue-red bar, this is HGA, high gamma activity. Sigma, this is the change. This is the power of change. So 3 folds, 3 standard deviation. So the red means there's increased high gamma activity. Watch. I'm going to show you. This is now, we are at minus 25 milliseconds. So this is before the movement is done. Supplemental motor area gets activated before the movement occurs. I'm going to play again. Now we are in the middle of movement. So the motor area is active. And late into the movement, a copy of the movement is sent to the sensory cortex, what we call efference copy or proprioception. So this is the wave of gamma activity over the cortical surface when you try to move your hand. Let's play it one more time. This is, by the way, slowed down 50 times. So this occurs, all this activity occurs in less than half a second. Do it one more time. Why is that important? It's important because it shows us which area of the brain does what, but it's also important because we could actually take that pattern and feed it into an artificial intelligence and machine learning and re-emulate the movement. So this is the basis of what's called brain-computer interface. So if somebody doesn't have a hand, have amputation, and we want them to move the robotic arm by the power of their thoughts, we could teach the machine that this pattern means grasping. So each time the machine sees this pattern, the hand moves. So this is what's called mind control. You can control an artificial device using brain activity. So now we told you about the older paradigm. Now, after all these things are now tools in our hand. We have the robotic stereo EEG, we have stereo EEG, we have robot, we have laser, we have closed loop device, we have improved mapping. So when there's all this and put together, do we still treat epilepsy the same like where I started? The answer is no. So this is the new paradigm. If you have a focal epilepsy with aligned or concordant data, we still do resection. If you have focal epilepsy with aligned data but deeper or wish for minimally invasive, now we have the option of laser ablation, which we didn't have. If you have focal epilepsy without aligned data, you can do intracranial monitoring, but now you have a much better methods of targeting and of diagnostic accuracy because we have stereo EEG. We can target any part of the brain bilaterally for up to 30 days. If you have focal epilepsy with ictal onset zone determined from the diagnostic surgery, you can either do resection or laser. If you have bifocal epilepsy, which wasn't treated before, now you can do responsive neurostimulation. Or if you have focal epilepsy but eloquent cortex, this patient is no longer not a surgical candidate. This patient can receive surgery. You can use RANS. If you have multifocal epilepsy, you can do vagus nerve stimulation or deep brain stimulation. If you have catastrophic epilepsy, you can do disconnection surgery, but you can also do it using laser ablation. As a result, that every epilepsy patient who is a medically intractable is now potential for epilepsy surgery. So the epilepsy surgery candidacy has completely changed. Pretty much any epilepsy patients can be a surgical candidate. So basically the candidacy now is medical intractability only. After failing 2 medications, medical intractability is common. 1/3 of epilepsy patients are medically intractable because if you fail 2 medications, the chance of control by adding a 3rd medication is less than 5%. Because of this change in epilepsy of technology, every epilepsy syndrome could be treated surgically. And not every epilepsy can be cured by surgery, but the epilepsy surgery success is different than epilepsy surgery cure. So cure means that you don't have no seizures and we stopped your medication. But epilepsy surgery success could be epilepsy surgery cure, or it could be no seizures but using medication, or it could be substantial reduction of epilepsy. These are called Engel class 1, 2, and 3A. But also there is another grade for successful epilepsy surgery defined by the International League Against Epilepsy, ILAE grade 4, which is 50% reduction of seizure severity and frequency. So while you may not cure epilepsy by every epilepsy surgery, you substantially reduce epilepsy and you can treat epilepsy and reduce epilepsy burden and change the quality of life for these patients. Focal epilepsy is potentially curable, and some forms of focal epilepsy are also potentially curable. You need to search relentlessly for focal epilepsy. So this is now the new paradigm, which is very different from the old paradigm in which we focused on temporal lobe epilepsy or extratemporal epilepsy because that's the only one you could cure. Now we have a very different outlook towards epilepsy surgery. As a result, the number of epilepsy surgery performed in any major academic medical center has increased perhaps tenfold between 2005 and now. Now, I want to show you one case study, one of the patients that we treated to show you the power of the newer technology in treating epilepsy and other conditions. And this one case has received a substantial media coverage, and we results in 2 papers, one in the prestigious Journal of Neuron, and the other one is in Neurology Clinical Practice, which is both big journals. So here's a story of this one patient. This is somebody who is 34 years old. She's a woman, and he has dual diagnosis of OCD and epilepsy. Now, she's 34 years old now. When I met her first time, she was 25. Her OCD preceded epilepsy, and both are medically intractable. She failed medical treatment for both. She presented for surgical evaluation after failing 3 anti-seizure medication. When somebody fails 3 anti-seizure medications, adequately dosed, and then you know she's not going to respond to any other medications, and she probably perhaps needs surgery. The problem is that she didn't have one type of epilepsy. She has semiology, which is the clinical syndrome of epilepsy, included 3 types: musicogenic epilepsy, which is epilepsy when you listen to a particular music or a melody or a sound; déjà vu, which is classic for temporal lobe epilepsy, which is déjà vu, automatism, blinking. This is all temporal lobe epilepsy; and tonic-clonic seizures, which could be a secondary spread or could be a 3rd type of epilepsy. So when we did video EEG, we captured 3 seizures, all of them from the right temporal lobe. MRI was non-lesion. So this is a condition we call non-lesional temporal lobe epilepsy. People with non-lesional temporal lobe epilepsy usually get a PET scan. If the PET scan is positive, in the old paradigm, we used to do temporal lobectomy. If not, we do stereo EEG. In this case, we elected to perform stereo EEG. And we did a SPECT scan, which is so temporal and thalamic activity. Stereo EEG, we did cover the temporal lobe, the limbic system, the parietal system, the insular system, and a couple of electrodes on the left side. So we covered large brain. And we found 3 regions in the brain, very similar to the 3 semiology. We found 3 distinct regions in the brain that cause epilepsy: the medial temporal lobe, Heschel gyrus, which is the auditory cortex, therefore the musicogenic epilepsy, as well as the right insula. It's a large network. So at the age of 28, she underwent right anterior temporal lobectomy because her temporal lobe epilepsy that comes from the hippocampal sclerosis was the most disabling, and she accepted that she can get rid of this one type of epilepsy and she could live with the musicogenic epilepsy. We done this, right temporal lobe, anterior temporal lobectomy controlled her right temporal lobe epilepsy but left the musicogenic epilepsy active. She elected to have a second stage treatment, which we call hybrid treatment. So we do resection followed by something else, which is responsive neural stimulation in the Heschel gyrus. Why didn't we remove Heschel gyrus? Because removal of the primary auditory cortex could result in impaired language or sound detection. So we didn't want to do that, even though it's non-dominant, because there's no robust data to say that removal of Heschel gyrus is safe, even in the non-dominant side. And you know that, the auditory dominance is bilateral. So both right and left Heschel gyrus are dominant. So at the time, patient said, well, I hear that, OCD could also be treated by brain stimulation. Could you treat my OCD as well? And this is an example of patient ingenuity. So we said, okay, since the machine can carry 2 electrodes, and we have 1 electrode in Heschel gyrus, why don't we try to implant the other electrode somewhere in the brain where it can treat epilepsy? Now, we know that the insula is also needed to be targeted. So I studied her brain anatomy, and I found that we could implant an electrode in which it targets both the insula and the nucleus accumbens. Nucleus accumbens is the part of the brain that's responsible for the obsessive and compulsion. And then she had an RNS device implanted in 2019 with 1 electrode in the Heschel gyrus. The second electrode spans the distance between the insula and nucleus accumbens. And that's the trajectory of these electrodes. You can see here, it's the most superficial black dot is in the insula, the deepest one in the nucleus accumbens. And the other electrode down at the bottom row is in Heschel gyrus. And then this is, again, the value of scientific collaboration. I learned that there's a group of Stanford that is trying to identify a biomarker for obsessive compulsive, and they studied that in rats. So I asked the patient to travel to San Francisco Bay Area, went to Stanford to my partner, Dr. Casey Halpern, who obtained her brain recording and analyzed them, and we really found the marker for her obsession. So each time she had obsessive thought, then brain changes. And we knew that one of her obsessions was against seafood, so we would actually present her with a picture of a shrimp and read out her brain activity. And the difference between OCD programming, we had to program each electrode independently. OCD is a chronic condition, while epilepsy is episodic. So we had to be able to program the device. We didn't know the biomarker for OCD. Stimulation is only responsive. The responsive neurostimulation doesn't have a baseline of stimulation. It's unlike DBS. It's only active when it sees a signal. And we wanted to make sure that we're not going to drain the battery life. And there is no previous, this was the first case in the world in which closed loop system was used for OCD. And this is what we do. We show her the shrimp here in the bottom. This is a neutral picture that does not induce the obsession. And this is a picture that shows the obsession, and we can detect brain activity. And here's the marker. The marker is what's called in the delta band. You can see the red line is peaked. So obsessive state, you did increase in the power in the delta band around 1 second. So we taught the device to look for this red increase. And each time it sees a red increase, it delivers stimulation in nucleus accumbens, which is independent from the activity for programming for epilepsy. Over time, we saw that her obsessive episodes went down and she's no longer obsessive. This took about 3 years from 2019 to 2022. And we can no longer detect OCD on her recording. So the patient is not recording symptoms, and we changed the brain by responsive stimulation of the nucleus accumbens. Therefore, this was an important case report because we found the biomarker for OCD. We were able to successfully treat it. But it was also the first case in the world in which a single device was used to treat 2 neurological conditions using closed loop system. And there's no other case reports like this in the world. The purpose of this is to show you that, epilepsy surgery has changed, but the technology could be used in other conditions. And as a surgeon and an academician, you should use your knowledge to try to help your patients and always think of ways to advance the field. The ingenuity is what we should strive for. And I hope that I showed you through this presentation that lasted about 45 minutes that epilepsy surgery has completely changed from what it used to be just 20 years ago due to the advent of multiple technologies and multiple methods. And we now use the same techniques and same methods to treat other conditions, even outside of epilepsy. And like at the end, to thank you everyone for inviting me to give you an overview on the journey of epilepsy surgery. and how it changed and the power of newer technology. Thank you again, Dr. Bennett. Thank you, Abdurrahman. Thank you, Ahmed. And I'm going to stop sharing.
Thank you.
Thank you, dear professor. First of all, I'm so appreciated for being with us tonight, and thank you for accepting our invitation. It is a great privilege for us to having you with us in this webinar, and I'm looking forward to having you in other webinars in the coming few weeks. So again, I'm so appreciative for you, and thank you so much. I wish I can meet you in person soon, inshallah. Thank you so much.
Are we doing any questions and answers through the webinar? I think if people want to type a question, I'm happy to answer it. This should be interactive. If there is a way to do so, I'll be happy to answer any questions or go back in the slides and go over other parts.
Okay. Goodbye.
Well, Doc, I'll start things off. I'm not a neurosurgeon. I'm not even a practicing doctor, but I did practice in the emergency room, and we used to have patients come in with epilepsy on Dilantin, on medication, and we'd of course run a Dilantin level, and sometimes it would be therapeutic. And really, there wasn't much known 20 years ago about Dilantin resistance and that kind of thing. So epilepsy is an area that education is needed. And also another thing I saw, it was some patients don't see a neurologist or a neurosurgeon. They see a general practitioner who are less educated actually than neurosurgeons and neurologists about the things that you were talking about. So certainly we appreciate your education, bringing us up to date on what's going on. And I thank you for that.
I agree with you. You know, access to epilepsy services, whether it's neurologic or surgical, is not widely disseminated or available. And we're talking about the US, so let alone the rest of the world. So unfortunately, there are countries and swaths of land in which epilepsy surgery isn't available for one simple fact. You know, big countries may not have a single epilepsy monitoring unit. EMU is a special unit in which patients are admitted and are allowed to have seizures while they're being video recorded and their brain activity is recorded at the same time. This requires infrastructure, and unfortunately, you know, very few countries. So I'm very familiar with the Middle East, and in the Middle East, there are perhaps 2 or 3 countries that have EMU out of 17 countries. So that's just an example of how epilepsy surgery it's kind of, it's very effective, but requires a lot of money and a lot of infrastructure and a lot of dedication. Now, not if I'm going to a country with economic challenge and I want to start an epilepsy surgery program, I wouldn't tell them go buy a robot. There's no reason to spend $1 million. At least do what epilepsy surgery used to do to be done here in the US 20 or 30 years ago. Just do the resective surgery, do the vagus nerve stimulation. That will be better than not doing anything. So I'm not actually arguing here that every place in the world should enjoy this technology. This is a maturation level. You get to that when you practice. But epilepsy surgery is effective. It changes people's life. Epilepsy is a terrible disease. It changes you are. It hijacks your life. You basically can't work, can't function, can't drive, can't be left alone. And your life expectancy is less. You know, people with epilepsy live on the average 20 years less than anybody else. Yeah, you can do virtual surgery with robotics. You can actually run the entire path through surgery, but that's for stereo EEG, not for. This is a question from Abir, but you cannot do this with laser. You cannot do this with RNS. But virtual surgery in the there is multiple companies that operate in the virtual reality world that offer you a chance to delve inside the brain anatomy before you do surgery.
Are there any programs that actively teach about surgery and epilepsy? Are there any
I think there is
regular platforms?
there is a couple of foundations that they may have some material on epilepsy diagnosis and treatment, including surgery. I think the most two profound foundations is the Epilepsy Foundation, and there's another foundation called Cure Epilepsy, both of which have materials on that. There's also the biggest society for epilepsy is the ILEE, International League Against Epilepsy, and they even have, but the ILE is not a patient or public-facing organization. It's an organization for physician. Cure Epilepsy and Epilepsy Foundation is a patient-facing and public-facing foundation. So if a public wants to learn, I think they should go to the Epilepsy Foundation or Cure Epilepsy.
Thank you. Okay, any more comments or questions from the panelists or
Okay.
anybody?
Yeah, there's a question about Amiga. What's your practice in regarding surgical treatment of insular epilepsy? Well, that's a good question. Obviously, the person who asked that question is somebody who does epilepsy surgery. So, insular epilepsy is the great mimicker. The problem with insular epilepsy isn't just the treatment, is the diagnosis, is to arrive at the certain diagnosis that's insular, and that can only be done with intracranial electrodes. So you have to first place stereo EEG or depth electrodes or whatever you want to do to get insular epilepsy. So insular epilepsy could be treated depending on the side, laterality, and the location. So if we're talking about the non-dominant hemisphere epilepsy, you could do resection except for a very posterior part of the insula in which you may get very close to internal capsule and you put the perforators at risk. So that part you could either treat with RNS or with laser ablation. On the left-hand side, if you have access to mapping techniques and are willing to do an awake surgery, you could also do an anterior insulectomy. And the posterior part, you can either treat with laser ablation or with RNS. So much my practice, I'll try to do resection if possible, if it's anterior, right or left, using mapping. If I cannot do resection, then I will do either RNS or laser ablation. Does that answer the question?
Yeah, yes, thank you. There's a couple more
Yes.
questions. Abir Benarama.
Yeah, I answered that question. I already answered it.
I'm sorry. Okay. Did you get the question of what is your practice with regards
Yes, I
to
did.
surgery?
I did answer
Okay,
those.
I'm sorry. Okay, well,
All right.
one thing I'd like to offer you, Doctor, that sometimes we have associations that have meetings like once a month for education. We could do that neurosurgical TV with your program if you'd like. Think about it. Once a month to have a webcast with education of epilepsy surgery.
I'm very happy to provide. I mean, epilepsy is my passion. I've done multiple podcasts and meetings regarding for education of the public as well as physicians. To be honest, it doesn't mean that this knowledge is available to all physicians. Most primary care physicians don't know anything about what I just talked about. Don't
No,
understand that the world has changed. And even though we have level 1 evidence to suggest temporal lobe resection, the number of temporal lobe epilepsy surgery has not increased as a result of that evidence. We have publications to show that. But I'm
okay,
happy to do it.
okay, very good. Any closing comments, Ahmed? Ahmed, you there?
Question for are you planning on operation on patients with psychiatric conditions?
Yes, there is an approved treatment for OCD, but not all psychiatric conditions. Certain ones. OCD could be treated by deep brain stimulation. There are active trials to try to treat epilepsy. When those become available, we'll offer them treatment. Yes. So psychosurgery is one other field of neurosurgery that is still, growing slowly.
In the United States, are mostly academic centers that have
Most academic centers.
epilepsy surgery in the US?
Mostly academic center or large private centers. So in order to offer epilepsy surgery, you have to have the infrastructure of EMU, There is a National Association for Epilepsy Centers, NAEC. Epilepsy surgery is performed in level 3 and level 4. And in order to get the designation of level 3 and level 4, you have to have a certain number of neurologists, certain number of surgeons, you have to have an MRI, you have to have a SPECT scan. So there is an infrastructure associated with that designation. And most epilepsy surgery, yeah.
Okay. Very good.
Okay. Uh, uh, thank you very much, Prof. Ahmed Rislan. Her presentation is wonderful and beautiful. We are happy to work with you.
Thank you. Thank you very much. Bye-bye.
Okay, thank you, Doc. And thanks, Ahmed. Thanks, everyone, for
Yes.
helping.
Thank you, everyone. Thank you so much.
Bye-bye.
Goodbye.
Thank you.
Goodbye.
There's